So thank you very much indeed to Carlos and Jonathan for inviting me to talk on this. And I think there's a lot of similarities in some of the difficult patients that we see. My name's Phil. I'm a spine surgeon, and I've been pretty much a pure spine surgeon for the last 10 years. And as you know, we don't really operate on back pain anymore. Oh. I'm going to do a declaration of interests, mainly because I hate the way Americans do them as disclosures, and they put it up for about half a second so that you can't actually see how much money they're getting. I have no financial interests apart from golf. I have past president of Eurospine. I gave up 3 years of my life to be a developer for the NICE guidance on back pain. That was published in 2016. So we reviewed 780 papers to come up with the guidelines on back pain. It was one of the longest, biggest guidelines that we've done. So I have the scientific background for most of the things that I'm saying, but actually tonight I'm going to be talking about mainly the hand, because you're all hand surgeons. You'll all have been leased by the Royal College of Surgeons. The head is knowledge, hands are skills, and they can be motor skills or soft skills like communication skills. And then there's the heart, which we know is really important as surgeons, and that's the judgment of wisdom of when to operate and when not to operate. That probably takes most of your career to develop. The way we're teaching at the moment, we would expect in a face-to-face teaching session that the candidates already have the knowledge that they need. It's the skills that we want to be doing on a one-to-one basis, or in terms of soft communication skills. That's what I hope to be offering you some of the skills tonight. The heart, judgment and wisdom, you know, it's really important around communication, and more we work as teams, and it's really useful to have that case discussion where you can refine and define what's good and in the best interest of your patient. So communication, this is what it's all about. When you're communicating with your colleagues, it's about teamwork and safety. When you're communicating with patients, I'd like to concentrate on improving outcomes and also some of the strategies that may be useful for dealing with difficult patients, or patients that you may perceive as difficult. Actually, the patients perceive you as a difficult doctor sometimes. And it's all to do with this thing that we were taught at medical school about labeling. Now, 50% of what I was taught at medical school was wrong. I just don't know which 50%. And this labeling is something that happens all through medicine. With back pain, we have this paradox. We have fantastically improved diagnostic imaging with MRI scans and CT scans and SPECT scans and all sorts of things. The actual prevalence of back pain, as you can see with the green line, has been pretty static, but the disability with back pain has increased considerably. And that's really societal rather than physiological. And that's why with spinal work, we've developed this bio-psychosocial model that I think is applicable to almost all areas of musculoskeletal pathology. It's just that some practitioners are more aware than others. So the difficult to diagnose, it's not difficult to diagnose back pain. Back pain's a symptom. What we have to do is exclude all the serious stuff. For you guys, that wrist pain that's non-specific and may have work-related issues to it. For the knee surgeons, it's anterior knee pain. And in the background of all of this is the sort of fibromyalgic patient who may be somatized and complaining of multifocal symptoms, and you just happen to have got them because their symptom is dominant in your specialty. So this comes to the traditional René Descartes reductionist medical model, which is something is broken, I need to fix it. To fix it, I need to know what's broken. And that takes you down this mechanistic pathway of pathogen, injury, this is broken, I can fix it. But if you can't identify what it is that's broken, it can be very difficult to fix. And if you don't know the natural history of the aging part of the body that you're dealing with, it can be very complex indeed. The bio-psychosocial model was developed in the early 60s and became refined and defined during the 70s and 80s as that's the societal things. And if you want to read probably the best text on this whole topic of tackling musculoskeletal problems, there's this book that's about £17, that's very good indeed. And it gives us the flags. I mean, in spine, we have the red flags, which are the things of serious spine disorders that help you pick up or help you train primary care practitioners to pick up things that are serious early on and refer them to you. We have the clinical yellow flags, and these are the various psychological or behavioral factors. We also have the blue flags, which are occupational factors around getting people back into the workplace and the obstacles to that. And then there's the black flags, which are some of the occupational obstacles to getting people back into the workplace. What's the worst thing that can happen with somebody with say, wrist pain or back pain? Well, you know as well as I do that chronic pain has many secondary effects: unemployment, depression, divorce, obesity and hypertension, excessive medication. There's a tsunami of gabapentin, pregabalin and tramadol out there for these patients. They have poor sleep patterns, and essentially their life is grim and miserable. And if we can improve it by something positive, we're doing them a favor. So you need a strategy for tackling obstacles. You treat the disease, you manage the illness, and you negotiate the sickness. So if somebody comes to me wanting a scan for back pain and they don't fulfill any of the criteria for an MRI scan, they're not going to get an MRI scan from me unless we enter into a contract, which is I'll scan you, and if the scan is normal, you're going to have to engage in a rehab program. And this is the problem that we have really, is that an injury we know has a normal sort of pattern of increased pain associated with tissue healing. And over a period of time, usually 6 to 3 months, that tissue will heal and repair and remodel. But the patients that are the challenge are the ones where the pain level continues despite the initiating pathology healing. And that's how acute pains become chronic pains. And it's pain associated with other processes, be that somatization or centralization of pain. Whenever we look at our operations, we have usually a sort of normal distribution, but there's actually a bimodal distribution where you have your best outcome group, and you can predict those yourself sitting in front of them. And then you have the worst outcome group, and you can also predict the ones that won't do well with your operation compared to the ones that do well. So you have a worse group, broader spread, and the difference between the two is related to these psychosocial factors. So if you can identify the psychosocial factors in the patient, you can give them a better outcome and a better quality of life. And if you give them a better quality of life, you give yourself a better quality of life as well. So in spinal work, I feel my neck click when I move, and that frightens them, so they stop moving their neck and end up with a very stiff neck. My discs are crumbling and damaged. That's a belief that's erroneous. And they come to you saying things like, nobody understands how to fix it, and I just can't bear any more pain. And this is the challenge that we have. So pain avoidance is a good example of a yellow flag. That is, oh, the last time I went to the gym, I hurt my back, so I'm not going to the gym again. And you're into a real mire of difficulty there if you don't address it when it comes up in the consultation. So pain avoidance is a fear of doing harm, and so they start avoiding activity and they become very passive and fearful of movement. And you see that all the time in the hand. You know, the ones that develop chronic regional pain syndromes and algodystrophies have often been quite fearful of movement, and then they get all the physical effects of having that stiff, swollen, painful algodystrophic hand. So the strategy that you have is, this is going to hurt, but you're not going to harm it. You're not going to make it worse by moving. We do lots of questionnaires with our patients before we see them in clinic, partly so that they start their assessment on time and our clinic figures look good, but also we gather a lot of information. So I would routinely do a modified Zung Depression Index questionnaire, which is 23 questions, modified somatic perception questionnaire, which is another 23 questions. And we use visual analog scores and functional outcome scores. So visual analog scores, you start to worry if anyone's scoring 10, and you really worry if they start adding their own scores in just to impress you with how serious their pain is. The other thing we see is the use of aids, and for us in spinal work, a blue parking badge is a sort of train crash coming in terms of disability. Neck collars. I've never prescribed a neck collar in my whole career. I don't know why anyone would use a soft collar. I'd use hard collars for trauma, but soft collars are the kiss of death. And you have these badges of disability. Collars with tinted glasses, perhaps mobility scooters, collars and tinted glasses, a couple of wrist supports, and also a guardian angel on their side. You might have had a little chuckle there, and that of course is cognitive dissonance, which is where you feel slightly uncomfortable with the image being described because you're so familiar with it. So we have these difficult heartsink patients. There may be patient factors. They often have medically unexplained symptoms, and there may be doctor factors as to why their heart sinks. The doctor factors actually are the ones that you can address and we can address as a group around training and these skills that you can pass on to people to help them cope. So doctors that label patients as heart sinks often have a greater perceived workload. They have low job satisfaction. They don't enjoy life as a hand surgeon. They're depressed. And we know in spinal work that if you have a depressed surgeon and a depressed patient, you have poor outcomes. Whereas if you have a happy surgeon and a happy patient, you have quite good outcomes. Sometimes the doctors are lacking in communication skills, and often they're perhaps not in receipt of postgraduate qualifications. So other things that happen, if doctors are insecure, they practice defensive medicine and order numerous tests. They may be angry doctors and see the patients as weak and then don't help them as much as they could. They may be very competitive doctors who want to show how clever and intelligent they are by ordering flamboyant treatments or lots of tests rather than relying on their own clinical skills. There's the overcaring doctor who wants to be loved by the patient, and they encourage dependency on the part of the patient by doing more tests, by never discharging them and keeping them coming back. And there's the doctors of perfection who find it very difficult to accept that they can't help everybody. The interesting thing about what we perceive as difficult patients is that they often perceive doctors as difficult doctors. And having that honest, open conversation with them can be very helpful sometimes. So obstacles to recovery, fears and beliefs, that fear of pain or a belief that you're inevitably going to get worse or end up in a wheelchair causes pain avoidance behavior and fear of movement. And catastrophizing. If I'm like this at 30, my goodness me, what will I be like by the time I'm 40 or 50? I'll be in a wheelchair. I won't be able to move my hands. I won't be able to use a keyboard or even move a computer mouse because my symptoms are going to just get worse and worse and worse as they have done for the last 6 months. So that's catastrophizing. So obstacles include distress and low mood. We know that depression will amplify pain. Uncertainty. So if a patient perceives that the doctor recognises there's uncertainty about what's going on, that can cause problems for the patient in terms of how they process the information they're getting from the consultant seeing them. And this thing of mixed messages. So sometimes we see patients have been doctor shopping. They've seen several doctors and they've had mixed messages. Oh, the physio said it was this. The last consultant said it was that. And you're telling me now that there's nothing there at all. And these mixed messages can be really difficult to handle. So you need to acknowledge these things, because the flags are not things that you can treat. They're things that you can manage. So the patient has these thoughts, and that produces feelings in the patient of uncertainty, worry, and distress. And then it also produces behaviors. So if you can identify some of the flags, like pain avoidance behavior, you can develop a plan about how to overcome that and get the patient moving, reassure them. And as you're doing your consultation, when these obstacles to recovery come up, that's the time to address them. Don't wait until the end of your consultation because you've lost the moment. You need to address these things as they come up during the consultation, which takes time. And it's fundamental that the whole doctor-patient relationship's changed. We no longer have this paternal patient-doctor relationship. We're equals to our patients. They can search on Google, they can look up on the internet, all sorts of things. And what we need to do is establish that we have a good rapport with the patient so that they'll accept the help that we're offering them, hopefully to produce a better outcome. So 95% of your diagnosis is made on the history. So effective communication skills are really essential. Start well. Treat the patient as you'd like to be treated. You know, introduce yourself. My name's Phil. I'm your surgeon today. Be attentive. Read the notes before seeing the patient and start with early eye contact so that you're engaging with the patient. And I like to ask open questions. The disasters occur when the patient walks in and just sees you looking at images and screens, and you're not then engaging with the patient straight away. And you've probably got about 10 seconds to make good contact with the patient. So before you get the patient in, make sure you're ready to greet the patient and get that good eye contact so that you're establishing an early rapport and you're there to help them. So time is of the essence. If you ask an open question, on average, a patient will talk for about 90 seconds. On average, a doctor will interrupt after 43 seconds. So you're missing about half of the information that the patient's going to give you. So listen. Start with open questions, keep on asking open questions, and then get on to the closed questions. Finally, ask relevant closed questions to clarify in your own mind the diagnosis or lack of diagnosis, and avoid jargon with the patient. What's my most useful question? How can I help you? That's so open that you often get a really good answer from the patient when you ask it. My most used question is, anything else? And it's been shown that that use of the two words, anything else, improves communication. Use it near the end of the history. It improves patient satisfaction in published studies, and this is the published study. So if you want to score high on patient satisfaction, when you've exhausted your open questions and you're about to move it into closed questions, or you've moved on from closed questions, just ask the question, anything else? Because words can hurt or they can heal, and you need to think about what your words do. Words are very powerful. What's said can be a major obstacle, this thing of mixed messages or raising the fear. Oh, that's the worst scan I've seen. And patients tell you these stories and you think, I'm sure the doctor didn't say that, but maybe they did. Clinicians are not always good with words. and the words that we use are very powerful. If you say something to a patient like it probably happened because of your work, it's going to be a challenge getting them back into the workplace. If you say you really need some time off, how long are they going to be off? And how does that reinforce their belief that what they're doing is harmful? If it doesn't improve, I'll have to send you for tests. Oh, so you don't know what's going on then. You're going to see what time does. In spinal work, the word that really is a dread word is degenerate. And unfortunately, we now have this MRI diagnosis of degenerate discs, which of course is a normal age-related phenomena. So degeneration is a very harmful word, and there's been good surveys done that show that patients think it means bone grinding on bone. So when you use the phrase degeneration in a wrist, think carefully about what the patient may be thinking and hearing when you say, oh, you've got some degenerate change in your wrist. Darth Vader is the dark side. Yoda recognized all these problems. Fear is the path to the dark side. Fear leads to anger. Anger leads to hate. Hate leads to suffering. And that's your patient with chronic pain. So what you need to do is a lot of reassurance, reassuring patients that some of these things are quite normal. We all use therapists. The controlled trials that have done are very difficult to control manipulation alone, because the therapist will often speak to the patient. And what we know is that it's probably more important what is said than what they actually do with their hands. Certainly in the spinal world, where we're dealing with physios, osteopaths and chiropractics. I think some of your specialist hand physios are really good at doing the desensitization and the positive reinforcement of it's going to hurt, you're not going to harm it. When it comes to pain, there's two ways that we work as doctors. We use cognitive and affective reassurance. We create this rapport, showing empathy, providing explanations, doing the reassurance, clear explanations and good information. So cognitive reassurance changes perception and belief through education. Affective reassurance, which is where you're a nice doctor, you bond with them, you reduce their worry, create rapport, and give the patient a sense of being cared for, is also important. Cognitive reassurance has a treatment effect of about 18 months, whereas affective reassurance, just being an empathic, nice doctor, has a treatment effect of about 6 to 12 weeks. Personally, I'd much rather give patients 18 months of reassurance, because that may result in changed behaviours. So we use a lot of educational tools in clinics, using the back book, the pain toolkit, the neck book and things like that, and sending patients to good websites that you can trust, that are done by specialist colleagues using words that patients will bond with. And this is the Eurospine website, which is currently available in 14 different languages. So there's lots of different strategies, and these are just a few of them. And I'm not going to go through each of them, but I'll pick a few out. So exploring, these are the questions. What do you think has happened to you? Why do you think that happened? What were you worried this might be? Communication skills aren't just the patient stories. You may have a reluctant patient or an angry patient, and very often they'll come with a friend or relative. For me, if a patient's got what I would call non-specific axial low back pain or disabling low back pain, I will acknowledge that some 85% of back pain is unexplained, and my role is to exclude the serious disease and try and get them better quicker. You've got the patient agenda, which may not be the same as your agenda, and you've got the patient's other agendas, which you need to pick out and try and dissect. So the doctor-patient relationship: take the patient seriously, listen carefully, examine thoroughly, never examine quickly. I'm going to examine you carefully, or I'm going to examine you thoroughly. but never say, I'm just going to do a quick examination, because that belittles what you're doing. Address the patient's concerns and establish rapport. You need to know why they've come along to you. And it may be that they're perfectly happy with their disabled status, but the primary care practitioner has sent them along to you because they don't know what's going on. There may be hidden agendas of medico-legal stuff in the background, so make no assumptions about what's going on. And hopefully by establishing good rapport, they'll open up with you. As I said, when something arises in the history and you think, oh, that's pain avoidance behaviour, or oh, they're catastrophizing, address the issue then. Don't wait until the end, because otherwise you've lost the moment. Is there anything else? What are you hoping we might be able to do? What are you worried it might be? And you need to ask the patient these things. There's the angry patient, and often you can see that coming with their non-verbal communication. They'll often respond well to the positive of how can I help you? In communication skills, we use ways of getting the patient to talk more with posture and nodding and grunting, mirroring and body language. And hopefully that way you avoid the angry patient, but I'm sure you've all had them. Explore the difficulties. You know, are you worried you're going to end up in a wheelchair? Or I suppose in that world of hands, it's, are you worried you're not going to be able to use a knife and fork? What were you hoping we might be able to do? What would you like to see happen? What would you like to hear me say? Ask the patient, what's the most useful thing I can tell you today? And see where their fears and concerns are, and ask them about what they think should happen. So misunderstandings are frequent between doctors and patients, and this is sometimes termed the heartsink patient. The problems arise with the patient's lack of participation in the consultation. You know, if all you're getting is grunts, it can be really difficult. It's often based on guesses and assumptions on the part of doctors and patients. The patient assumes you're not going to be able to help them. As a doctor, you think, well, I don't think I can help this one. You might summarize the whole thing. A really important thing is the significant other in the room. So I'm always pleased if a patient comes along with their partner, and I know that I'm going to have to be addressing the partner and treating the significant other in the room. Significant others often have the fears and beliefs, and they're reinforcing all the attitudes. So getting them on board with your treatment is really important. And that's where what I'll do is give the significant other in the room the back book to have a read of while I maybe go and examine the patient. You've got to engage with them, because otherwise they can undermine everything that you're doing. And find out whether the significant other is being a help or a hindrance, because you want to know if they're part of the problem or part of the solution. So it's all about listening, really. Positive messages and reassuring phrases. Mixed messages from healthcare professionals. Don't be too critical of anyone else's management to date, because that, if you're criticizing a previous colleague who's seen the patient, what you're doing is you're criticizing the whole of the medical profession. It just undermines the patient's faith in clinicians generally. Monitor yourself. Reflect. You know, that's what the GMC are telling us all the time, is reflect on your practice. And that can be challenging, because labeling patients is a coping strategy that we use as healthcare professionals. A label becomes a diagnosis. The diagnosis means that you understand it. And understanding means you have control of the situation. And it's really important that you just accept the fact that some things are difficult to diagnose and treat. Some things have no precise diagnosis, and managing uncertainty in medical professionals is an acquired skill. Monitor yourself. If you're seeing a lot of demanding patients, you often feel overwhelmed, inadequate and frustrated. And a common thing I get told is, oh, I've only got 10 minutes to see each patient and therefore I can't give them the time that you're demanding. You're far better off seeing one patient properly than 10 patients inadequately. Because if you're not in control of the process, it produces fear, anger, and uncertainty and despair. And if it's happening to you, it's happening to the patient as well. So discuss challenging patients with colleagues, be frank about how they make you feel, and seek advice. And that's where multidisciplinary teams and case conferences can be really useful. Key messages. The patient should be doing most of the talking. Consider the obstacles to recovery. Examine carefully, never quickly. Use cognitive reassurance because it's really effective. Determine the patient's agenda. And that's my favourite question. Anything else, which I hope that you put on all the chats. Thank you very much.